So, with curriculum design, results or outcomes drive the program. It's all very analogous to the sort of PDSA cycle that one gets in quality improvement. You're going through the same steps. If you notice, so many of these sciences, quality improvement science, implementation science, educational science, and even the science of CME, use very, very similar models. Unfortunately, the language and the language involved is often confusingly different, and that's why I'm trying very hard not to use too much psychobabble. Edubabble. Please, correct me if I do break into it. Okay, the what and the why. Identifying the content, as I mentioned earlier, is all about this gap analysis. And it all depends on who your target audience are. It has to be specific to them, and it has to be a mixture of what they feel they want to know. But also you have to try and figure out what it is that they don't even know that they don't know, and use some objective findings to identify the sort of needs that will really help them. Because quite often, if you don't know what it is that you want to know, how are you going to fill in that classic survey that one gets from a CMU organization? And these are the sort of things that you get from looking at the local statistics and looking at, for example, access rates. And if that's what you're trying to achieve, using that as a measure, baseline measure on which you want to improve. When anybody involved in doing any teaching whines like mad when they're asked to define the objectives. But unless people know what it is that they're expected to gain out of it, how can you possibly assess that endpoint? And this is where you are identifying your outcome, your metrics. So, how? Implementation of this. Well, what you've got to do is find the right sort of method to fit in with what you want to do. If you are trying to teach people how to use an ultrasound probe, you don't do a lecture. You may start with a little lecture, but unless people actually do it hands-on in some sort of skills lab, it's not going to work. There's a lot of good CME evidence, CME science evidence. And we know from this that what impacts on practice are complex interventions where many modalities have used. One of the seminal pieces of research has looked at the impact of continuing medical education and shown that lecture-based learning does not translate into improvement on practice, but in fact, multiple mixed methods do. There's a whole long list of different sort of things that can be classified as educational interventions. And again, you'll see that these are common to many other of the other ways of implementing change. But the educators want to keep them. The third thing, the event. Okay, so the learning environment is so important in the delivery. And recognizing things like biases and conflicts right up front, something that is so very controversial at the moment, particularly in North America, as demonstrated by recent controversy about in Astro, people having to declare their lack of conflict of interest before they got a latte that hit several of the newspapers. But you still also need to know things like who came, but particularly who didn't come, because these are the people that you're trying to reach. And if you can't reach them and you can't bring them in, what are you doing wrong? Again, there's the logistics that tend to contribute mostly towards that satisfaction thing. But unless people are satisfied, they're not going to come back. Did that work? Because obviously, if it didn't work, we're wasting everybody's time and money. So, when you look at this final overall thing, the identifying and measuring the gap are incredibly important. And these two steps here, the implementation and planning of the event, the actual delivery of the event, have to just be closing that gap. Just using some examples of the stuff over the amazing stuff that I've learned over the last few days. Let's go through some of this pyramid. If you want to run a course in Ghana on core needle biopsy techniques, you certainly do want to know who your attendees are, That is something that is very measurable. But if you notice that so many of these outcomes are not just quantitative ones, they're also qualitative ones. So you want to be able to get hold of people and say, why did you come? And perhaps think in terms of focus groups to identify some of these factors. And some of the things that you may identify may become measurables later on. A lot of them probably won't. As I mentioned, people have to be satisfied, otherwise they have to feel that their needs were met. And that's, again, a very subjective feeling, but something that can be recorded on a Likert scale. Assessing learning. Well, learning can be several different things. Learning can be skills and attitudes as well as knowledge. But what one really wants to know is one wants to know about shifts in this. So, for example, using an audience response system, one can do that because some of the questions have been provocative, sort of perhaps deliberately not having right answers, just to see how people's opinion, get an idea of people's opinions. But you can also use that to see whether a certain set of presentations shifted people's thoughts in any way, and therefore improving awareness. But of course, what we really want is performance. So again, with fine needle aspirates or with sort of core biopsies of breast lumps, unless people are actually able to learn how to perform this using some sort of simulation or with work in the OR or whatever, and this is properly assessed by looking at the biopsies in the pathology department, for example, and ensuring that they're adequate, one's not getting an idea of whether somebody has accomplished that goal. Most of all, though, you want to know that that is sustained and that they're going to be able to do it. They're going to be able to do it months and years down the road. Because if they go home and they don't actually do it again for another 3 months, you can be fairly